Okay, just a second. Perfect. And I will pass to you the command again. And give me only a few seconds to introduce you. You are on command right now, Dr. Gundetti. Thank you. You can put your talk again, please.
Okay, all right. So let me see here. Let's see. So I think, do I have to join, share the screen?
Perfect.
You can see better? Perfect.
Yeah, I can see, and you can put on presentation. That's right. Okay, just give me 2, 3 seconds to introduce you, Dr. Mohan. You don't need, but I will do that. Thank you. Muchas gracias a todos por su presencia, siguiendo con nuestro curso de educación continua en urología pediátrica. Es un honor para nosotros tenerlo al profesor Dr. Mohan Gundetti, profesor de urología pediátrica y también miembro de la Universidad de Chicago en ciencias biológicas. También director del Servicio de Urología Pediátrica del Hospital Comer de Children's de Chicago. Dr. Gundetti, thank you very much for your presence, and you can begin your talk. Thank you very much.
Thank you. It's a great honor to share some of my learning experiences in regards to minimal invasive surgery, and appreciate your wonderful academic activity, bringing all the speakers around the world and using the virtual platform. So this is great. Thank you. I appreciate it. So quick question, are you able to hear me better? Are you able to see the slides better?
Yes, it's okay.
Perfect. Okay. All right. So what I'm going to share today is a little bit of my experience in regards to minimal invasive surgery of almost 3 decades, the laparoscopy, and then, into the robotic surgery for the latter 2 decades. Now, before I start, I always like to acknowledge all the people who make this happen. Either it's the resident, fellows, my co-faculties. They are immense contribution to all of the work we have been doing it here. So that's a big thank you for everyone here. This is a beautiful campus of University of Chicago, which is south of the city of Chicago, where like-minded people are here to work on enriching the humanity. Either it could be medicine, it could be law, it could be business, but we all are on the same campus to do this work. It's a beautiful city of Chicago skyline in the evenings. So why we are here? I think one of our compassion to take care of children is to reduce the morbidity. And that's why we are here. We make so much effort every day. What can we do best? How we can improve. And it is all to reduce the morbidity, because we know that any procedure you do, the children do suffer. And our plan is not to do the procedure if it's not required, but if you do it, how you can reduce that morbidity. And with that compassion, we all are here. Pediatric surgeons are actually the frontiers in minimal invasive surgery. Far before the urology surgeons, far before any surgical specialty, because I think everybody understood that compassion to take care of children. And it goes back to 1970s, almost 5, 6 decades ago. The first thoracoscopy or peritonioscopy was done at UCLA by Dr. Gans. This is an incredible achievement. And the OB-GYNs were the next 4 frontiers. So the OB-GYN and the pediatric surgeons have really advanced this specialty of minimal invasive surgery. And this has led to, the immediate outcome measure, which everybody really liked it, is about the scars and the aesthetic appearance. But we're going to go beyond this. we're going to see beyond this, what is that advantage in doing the minimal invasive surgery. As I mentioned, I was a very early adopter of laparoscopy surgeon. For those who know the famous adult urologist, Dr. D.D. Gaur, a pioneer in retroperitoneoscopy. And I trained with him for adult retroperitoneoscopy, where we started doing the nephrectomies, partial nephrectomies, stone management in India about 3 decades ago. And that inspired me to continue to do minimal invasive surgery. And I think that the passion to take care with the minimal invasive surgery remained very active. Now, what's happening in the United States? In the United States, if you look at this graph here about the minimal invasive pyeloplasty, this yellow line is the endopilotomy, the green line is the robotic surgery, and the blue line is the laparoscopic surgery. And if you look at it, everybody got excited with the endopilotomy for pyeloplasty, for uretropelvic junction obstruction, because it was very minimal invasive, but remained very flat. And the laparoscopy was, it was a good adoption, but then in early 2000, it came down. That's because the robotic took over. And it felt that probably the robotic has some advantage compared to the laparoscopy, and that may be the reason that you can see that change. So there's nothing wrong. Laparoscopic surgery is fantastic minimal invasive surgery tool. It works very well. It's easily available and accessible around the world. But the problem is it has limitations. It's two-dimensional. It has ergonomic restrictions, and it's often difficult in regards to complex reconstruction. We surgeons spend our life to get trained, and we do need to function for a longer time of the life. But laparoscopy has caused some occupational hazards, and some of the expert surgeons do have to take the earlier retirement just because of the number of occupational hazards they had with the laparoscopic surgery. These are all musculoskeletal dysfunction, and we need to be very thoughtful about how we can prevent this. Similar problem about the ergonomic injury across the surgical specialties. If you look at it, all the people who are using minimal invasive surgery, they do have this suffering problem. And it tells us that if you think about the laparoscopy, open surgery, and robotic, I think the ergonomic injuries may be a little bit less or not there when you try to use the robotic assistance. So what is the fascination with the robotic assistance? We have been fascinated as a surgical colleagues, not only just a decade, but it's been almost about a couple decades. The orthopedic surgeons were at the forefront of using the robots to fix the joints. And then, probably in late 80s, you had a pro robot where you were putting the scope in a place for doing the endoscopic resections. And subsequently in 90s, the ESOP and then the robotic birth came in. And I think it's continued to evolve. It's just not us. I think, back in the eras of almost 6 centuries ago, everybody got fascinated with the automation, including Leonardo da Vinci. This is his mechanical model of a mechanical monk. And he wanted to see how this can work on with automation. To the extent, if you see the automation was used to make the coins, the transaction, and the currency. So it has been fascinating for human beings. And it's very widely used in industries. Industries where there is a complex chemical composition needs to be transported, complex machines to be transported. We have used the robots because we wanted to spare the human beings of their potential. For those who know Rich Satawa, who is a pioneer robotic surgeon, he came with a quote in early 2000 that, open surgery is there, laparoscopic surgery is there, but I think we are evolving, and we are evolving into bites, and it's no more blood and guts. And it fitted very well with the technological innovation and paradigm we have in the biointelligence era of 21st century going into 22nd century. So for those who have not seen the robot, what is this robotic surgical system? Is basically the arms, which are basically controlled by the human surgeon sitting at the consoles. The arms bear the instruments which are placed in the abdominal cavity. And these instruments have a 6-degree freedom of movement. And there's a three-dimensional vision with a 10 times magnification, which allows us to handle the tissues, which allows us to suture the tissues much precise and much better without much damage. And that's what this system looks like. And currently there are multiple different companies which make the systems and they're commercially available for use. So who are the four frontiers? And if you look at it, pediatric urology and surgery has reasonably done very well. If you look at the 2003 starting the adoption and see 2016, a big, huge number of publications in regards to pediatric surgery and urology. And geographically, United States, probably 2/3, but rest of the world has caught over. Europe, South America, Southeast Asia, India, and China has caught up, and that contributes to 25% of the robotic adoption. I started my journey back in 2005 at Guy's Hospital in London, where Mr. Patrick Duffy and Imran Mistaq, we did a first pediatric robotic pyeloplasty back in 2005. And we were stimulated by actually Prakash Gupta and John Wickham, who is a famous adult urologist. And he thought about this robot when I showed the Pro robot, and he used to use for transurethral resection of prostate. And that's how we got fascinated back in 2005, and we dwelled into the robotic surgery. With my MOOC getting recruited to University of Chicago in 2007, I continued to get fascinated with the technology and started getting into adoption. And it was some of the families and some of the friends and the patients' parents said that, why can't you do the robot? For example, the small baby came in, a professor's daughter saying that, can you use it for my baby? She's 7 or 8 weeks old. And that led me to push the boundaries beyond. The number of surgical procedures done, I'm sure everybody knows about it. Every intra-abdominal organ can be repaired with a robotic approach. And since 2002, 2008, the complex procedure performed by us, and this list continues on. But you need to take a pause. And whatever we do, we need to ask about why we're doing it, how we can do it, and what can we do better. So this is very important, and it's a philosophical question, but I think, you do need to step back and say, why we are doing it. Can we convince other people to think about this? And that led me to think about more, and this is the next portion I'm going to discuss. My experience is of last 20 years, about 500 cases, and of those cases, mainly 1/3 is pyeloplasty, 1/3 is reimplant, and 1/3 comprises of bladder augmentation, catheterizable channel, bladder neck reconstructions, heminephrectomy. So you name the case. So that's how 1/3. So these are single surgeon 500 cases at University of Chicago. So what are some of the procedures which are very commonly done? Of course, everybody knows that being a pediatric surgeon and urologist, pyeloplasty is a common procedure. That is the uretropelvic junction obstruction here. And you remove that uretropelvic junction, spatulate the ureter, and join the spatulated ureter to the renal pelvis. And if you look at this, the video, the handling of the ureter, the handling of the tissue, the suturing is very precise. And you're not struggling much ergonomically for anastomosis. Also, the view is 10 times magnified. That's what we need for pediatric surgeons and urologists. We want magnified view because our tissues we deal with are very precise, very fine, and I think it all helps to get a better outcomes. So that's a pyeloplasty shown here. We are using the 6O PDS sutures for anastomosis, and usually I put the cutaneous stent so we can remove this in an outpatient clinic. The next procedure is a heminephrectomy. For those who know the duplex kidney, Whenever the upper moiety is not functioning, you have either option of ureterostomy, but I prefer to remove the diseased function. And you may say, laparoscopically, it is absolutely fine. And I agree with you, laparoscopically. So this is the ureter dilator of the upper moiety, which is very tortuous and dilated. And laparoscopy is absolutely fine. I have done laparoscopy, I have done open. But what I found is the handling of the vasculature, especially this move where I'm trying to pass the ureter underneath and dissect the vessels, is much better, much precise. And I'm not putting a traction on the lower moiety vessels so that I can preserve that lower moiety. So that's a better use of the robot to preserve the lower moiety kidney and lower moiety vessels much better than the diseased portion. So that's where the benefit comes in. So this is the upper moiety ureter. We took down all the vessels leading to the upper moiety, and then we will remove that upper moiety diseased segment. So that's the use of the robotic technology for dissecting the vessels, which is really beneficial. The next topic is ureteral reimplantation. Reflux being the primary reflux being treated when it's a high grade, either you can do open surgery, you can do laparoscopic ureteral reimplant, or, I tend to use the robotic assistance here. And we coined the term to standardize the steps called as LUA, that is the length of the detrusor tunnel. Usually it's about 4 centimeters. U is the advancement suture. A is the including adventitia in the ureter, and then the apical alignment suture. This is an extravesical technique, and we use it for unilateral reimplant or bilateral reimplant. You take care of the ureter handling very well with the umbilical tape. In that way, you can preserve the vascularity of the ureter, you can preserve the adventitia of the ureter, and once you dissect the uretrovesical junction, preserving the neurovascular bundle on dorsomedial location, you can do the detrusor tunnel on the bladder. And once you do the detrusor tunnel, then you can put the ureter in that detrusor tunnel and close the detrusor muscle. I tend to get about 4 centimeters of detrusor length for the tunnel. And it has been tough because you may read the literature about the various outcomes. And I was trying to get the steps standardized and coin the term so that it is very easy to transfer across our peers and colleagues. We do tend to do a wide dissection here to preserve the vascularity of the ureter, and the uretrovesical junction anatomy is satisfactory. So that's for the ureteral reimplant. You can use this assistance. The next thing comes is the complex reconstructions like augmentation cystoplasty and catheterizable channel. Again, very similar to open surgical steps where you can take 20 centimeter of bowel, detubularize it, you do the cystotomy, and then do the bladder bowel anastomosis. For those who need appendicovesicostomy, you can do the posterior wall appendicovesicostomy, and if some needs a bladder neck reconstruction, you can do that at the same time as well. So as I mentioned that, these all procedures can be done, but then again, question comes in why we are doing it and what are the advantages you have and how can you convince our peers and colleagues and the patients that this is working. Of course, remember, we medical fraternity are tough people. We are very, enthusiastic, but at the same time, we want to know if it is really important. And this quote goes very well. The most entrenched conflict of interest in medicine is a disinclination to reverse a previous opinion, because we all have our fixed opinions. It is very important that the newer technologies and innovation before adoption should go the ideal group of innovation as designed by the Oxford team of group of people. But I think for robotic, we are currently into the long-term study. I don't think we'll be able to do RCTs, but we have done exploration, we have done development, we have done assessment, and I think we are in a stage of long-term studies. Remember, we surgeons are a part of the team. We've been helped by So many people, including the anesthetist, assistant surgeon, the surgical scrub tech, the medical team, and they all need to work harmoniously together. Otherwise, it's very difficult. But in spite of that, we do need to do assessment to convince our peers and colleagues. So how can we do it? I thought, maybe we can look at the morbidity, we can look at the outcomes, and also some parental gains in addition to the cost benefit of what we are doing. So I started looking at the outcomes of pyeloplasty. If you look at the laparoscopy, we're not talking about laparoscopy, but if you look at the robotic pyeloplasty, when back in the days of early 2000, the success rate was 86%. But if you move to later 20,000, 2000s, it's almost 95 to 98%. So this is a reasonable success rate. It's very enduring. So I think there is a benefit. What's happening with the vesicoparietal reflux, anti-reflux surgery? This is our multi-center study. And when we looked at the radiographic resolution on VCUG, that's almost about 93%. So that's very reasonable in regards to the use of robotic technology. What about the complex reconstruction? Similar, the robotic versus open cystoplasty, they had very reasonable outcome, except the surgical time for robotic was high because expected because of the learning curve. But the complications of the grade 3 were very similar. Reimplantation, the urinary retention rate are much, much less compared to open. For those who have done open surgery, they will know the urinary retention was much common, but this was very possible to avoid with the robotic assistance. The pain medication requirement is, of course, much less when you compare with open because you're not burdening with the tissue damage. This is our past study of 1,000 patients, multi-center robotic surgery. And if you look at the complications, non-procedural related, they were not much different. So I think, that shows the acceptance. But there may be some unperceived benefits. What are those unperceived benefits? That is, we not see it. We are not able to measure it. For example, spina bifida patients having the cystoplasty have increased incidence of obstruction because of the bowel adhesions with open surgery. So we wanted to see this in laboratory where we did a 10 augmentation cystoplasty in robotic approach and 10 in open approach. And when we compared the both and opened the abdomen after about 6 weeks, the scar was much higher in the open surgery, but natural expected. So it shows that there are some unperceived benefits we are not able to measure with the robotic assistance. There's always a safety concern. It all depends on how good you are a driver, okay? You are a good driver, of course, you're going to drive the car much better. If you are not a good car driver, I think you're going to run into trouble. So that tells us that technology is always neutral and is operator dependent. Is space a concern? It is a concern for small space because we have a generic system, but we have some of the tools. We can work on the nuances and we can overcome the generic system to fit into our adoption of pediatric use. So when you start training, you need to focus on few things. And the most important thing is the culture of remote access to the patient. You need to learn that because we are all used to staying close to the patient and doing the surgery, but here you are staying away from the patient. So you need to understand that. The tactile sensations are not there, but it can be compensated by visual cue of three-dimensional vision in the future. The space, you need to look into how you can work in a small space. And the case volume is important. You need to repeatedly do these cases so you can get better at it. So how can we do this training? So all the time, you need to ask question yourself, why we're doing it, how we can do it, and what we can do it. Remember, the learning curve is there for any new procedures, any new technologies, and it actually a burden on the patient because we are putting the footprint of our education on the patient. And if we can do training better, we can reduce that learning curve. Road is going to be a long, but it's going to be a non-ending road, and you have to have passion. You have to have patience and perseverance. And then I think the training will be effective. Where is the training analogy come from? I think the lot of similar training came from the flight aviation modality and flight simulation. And if they can do using this technology much better, why can't we do as well? Though, our constraints will be human being has so many variation, but adopting that simulation technology has really helped us to understand and learn the robot much better. If you look at the evaluation, dry lab or simulation is one component, but you have to have a wet lab and cadaver training. I think that's very important and crucial for your training purpose. For some, those who have spent some time here, we do have some of the wet lab training called as a mini fellowship for enduring this technology. You also need to think about as you starting this program, do you have a coach or a mentor who can help you out in the initial cases? Because it's a teamwork. It's you as a component and a key lead factor, but of course, you need to have a team to win the game. How do you want to start? I think, you should start with a simple pyeloplasties in a grown-up children. And then once you have a little comfort zone, then go into reimplantation, heminephrectomies, and complex catheterizable channels. This is my suggested training. It's the stepwise training, spend some time in a center, do a dry lab, do a wet lab, attend some live courses. And once you start doing it, then, make your good team, have a proctor come in and critically assess yourself, what you are doing right, what you are not doing. Little bit touch base on a financial aspect is going to be costly. Remember, it's a capital cost, and that capital cost is needed just because to buy your system. But this capital cost is temporary. If you can effectively utilize the technology and you can be productive, you will cut down on the cost. For example, if you look at this here, you can do the road work manually. You can do with the automation as well, and automation will add to your efficiency. This is a cost analysis study done by colleagues in Indiana, which shows that once you have the base capital cost covered over a period of time, it does pay for yourself. So I think cost is temporary. This is huge table. We put it in. You can look at the publication. One of the important thing you want to think about is the hospital is going to get the downstream revenue. That means you may be able to draw non-surgical patients, non-specialty patients to your hospital. And I think that you need to embed into the hospital administration system. Also, when you are developing the program, try to work with different specialties so you are cost effective and all the surgical specialties can come together and make this program happen. Remember, as you're going through, once you become an expert, start thinking about what you can do better and don't try to make mistakes. And this book is very example of once you reach the peak, what you can do and what you don't do it. What's the future? The future is always bright. It depends on how you look at it, your reflection. Some of the things we need to think about is, how can we reduce the surgical training and how we can do better? And can we go deep in regards to the electroencephalography of the brain and see who can be good at it? We can also think about using the telementoring and teleproctoring with the current digital technology. The role of augmented reality and 3D printing, we can incorporate that into the overall ongoing learning mechanism, and that could also reduce the carbon footprint of education. The machine learning and AI could augment our learning and positively criticize our mistakes. The research is going on in regards to automated suturing, and I think that could be the future of the incorporation into this digital platform of technology. There are multiple number of robotic platforms. As I mentioned, they are around and they are in use. And the other specialties which are catching up are especially the general surgeons and hepatobiliary surgeons because they find a lot of advantage using this system. The market is huge for those who are interested and is going to be the just a part of our armamentarium in the operating room. Remember, this digital platform is not just a part of minimal invasive surgery, but it's for future telerobotic surgery to reach those who are not able to receive such treatment. The robots are going to be complement us. They're not going to replace us. There are huge challenges again, especially the training and the cost, but also miniaturizing the instrument for our pediatric use. So follow the passion, follow the perseverance, follow the ethics, and share your experience with your peers and colleagues and learn from each other for betterment and ease of application. So my suggestion is your dedication, your passion, your perseverance is important. Have a proctor to help you out and keep practicing and self-critically evaluate. Just a few slides about how, as a surgeon, we can reduce the global poverty. Because if we can make one child better and being capable of productive life, I think he or she could be a good, responsible citizen to the country's economy. So I think we are contributing to the global poverty, mitigating it. This is our family in Chicago. I'm always grateful for them. And if you want to get people to do something, make it easy, remove the obstacles. I hope this quote remained well with my last 30 minutes of sharing my experience with you. And so we are what we repeatedly do. Excellence then is not an act, but a habit. So thank you all for giving me this opportunity. And I don't know if we have a question answer session, but I will hang around for a few minutes to take a few questions. So thank you.
Thank you, Dr. Gundati. Thank you very much for your amazing talk. I will see we have a question here. Okay, no question, but I have one question for you, Dr. Gunderi. Do you think that the people have before laparoscopic training get more easy to do the robo, or the people that don't have any connection with laparoscopic before, which one do better robo?
Yeah, very good question. Thank you. So I think, it works both way. One is the benefit of laparoscopy is, you have some skills of endoscopy, hand-eye coordination, the depth perception. Those are the pros. But what I saw is when I was teaching some of the surgeons who had a good laparoscopy skills, is it's very tough to de-learn what you learn. And what does that mean is, during suturing and laparoscopy, you always hold the needle. You never let go of the needle, okay? But in robotic, you have to drop the needle. If you hold the needle, then you break the suture. So that's one thing. The second thing is in laparoscopy, we always, have a two-dimensional. So when we suture it, we, push and pull. But in robot, it's a 6-degree freedom. So you need to move the wrist joint. So couple of those small things get very hard. If you have a laparoscopy skills, that's fantastic. You can just adapt to the robotic and just forget about what you have something learned in the laparoscopy. If you don't have it again, don't worry about it. It will teach you all the things intuitively in regards to the depth perception, in regards to vision and suture handling. So I think, in either way, both of them should need to learn, and there is no pro or con of having a good laparoscopy or not laparoscopy.
Si alguien tiene alguna pregunta, si alguien quiere realizar una pregunta, por favor puede escribirla en el chat. Yo haré la pregunta al profesor. I have another question before somebody asks you. Dr. Gundetti. Which one of the laparoscopic procedures do better than robotic? I know that the question is hard sometimes, but you know, in South America, we have very low, some countries have robo, but the majority of the countries don't have. So from your point of view, which one should be better do it by the laparoscopic than robo?
So, for example, in our institution, I still do laparoscopic orchiopexy. Like this morning, I had a laparoscopic orchiopexy, and I think it works well. It's easy. You don't have to waste money. Last week, it was a laparoscopic varicocele. So for varicocele orchiopexy, still is very easy to use laparoscopy where there is not much of a suturing involved. There's not much of a dissection involved. And I think these procedures we need to continue to do with the laparoscopically until unless the robot becomes very cheap or easily available is a different question. The other thing why we need to do this laparoscopically is we do want to keep some of the laparoscopy skills up. Suppose you are in a location where you don't have a robot, or someone suddenly if there is a robotic malfunction, you know how to do it. Of course, you can convert to open, it's not a big issue, but having some of the basic skills, like riding a bicycle is always helpful, isn't it? Even if you drive a car, riding a bicycle is always helpful. So I think that's my thought process in regards to laparoscopic orchiopexy and varicocele. In regards to the nephrectomy, choice is yours. If it is a non-functioning kidney, if I have to do a nephrectomy, I still tend to use the laparoscopy, just to keep up the skills and have the residents teach laparoscopic nephrectomy. But if it is a Wilms tumor, if it is RCC, again, our adult urology colleagues are using the robot because they find the vasculature control and the maneuverability is much, much easy. So that's my thought process on where to use laparoscopy and where to keep the robot for current use.
Thank you very much. And the last question from my part is the smallest baby you do robo, which one is the smallest baby?
Yes. That is very individual and subjective in regards to your experience. When I started, we used to do like 5-year-old, then we slowly gone on to 2-year-old. But if you ask me now, the youngest pyeloplasty we did it, or I did it on a 6 weeks baby. 6 weeks baby, it was like 7 kg.
Okay. We have a question here from Mauricio, Dr. Gunderi. What is your opinion about the ex vivo simulation model, for example, chicken models in pediatric urology?
Yeah. So I think, XYO, any model you can use it as long as you are able to suture, handle the tissues, dissect the tissues. And it will depend on what is available and what is allowed in your institution or in your country. Um, I think that it's very replicable because what you're trying to do is the suturing delicate tissues and handling delicate tissues. So absolutely fine, whatever is allowed and available in your region.
Dr. Gundetti, thank you very much for your amazing presentation and for your kind presentation here in our webinar. We do appreciate your presence. Thank you again very, very, very much.
All right. You all have a good day. Thank you. Take care. Bye.
Bye bye. Para los que todavía están conectados, les pasamos que la próxima presentación lo vamos a tener invitado al doctor Rafael González, octubre 11 a las 8 de la mañana, quien nos va a exponer hipospadias complejas, reparación por estadios. Así que quedan todos invitados, ya les mandaremos el link para la presencia de cada uno de ustedes. Muchas gracias por estar presentes. Un abrazo.